Hello, welcome to this video where we are breaking down the 15 lead. What's 15 lead? Why is it warranted? And isn't a 12 lead good enough? A 15 lead, simply put, is a type of modified 12 lead where we are taking 3 additional leads and we're putting them on the patient to gain perspective of the posterior wall and right ventricle. Those 3 leads are V4R, giving us perspective of the right ventricle, and V8 and V9. That's going to give us perspective of the posterior wall. This video is going to take a look more at the why behind the 15 lead, and I'm going to attach the video after this kind of demonstrating how to place those leads. So let's take a look at our normal 12 lead, and we'll kind of use that as a stepping stone. All right. So here I have a relatively normal looking 12 lead. I have colored circles and letters next to each lead that are corresponding to different portions of the heart. A way to remember these portions in an organized, systematic way is kind of crude but effective, is Lee, ass backwards, all. Lee, ass backwards, all. So I have lateral, inferior, inferior, lateral, inferior, septal, anterior, anterior, lateral. So if I see abnormalities in the, we'll say, for example, septal and anterior leads like we do here, we have ST depression in these leads. That's kind of strange. I'm going to keep note of that. Sorry, not here, not in V5. I got V2, V3, and V4, we have ST depression. That's strange to me. Let's use that as a stepping stone for the posterior STEMI, and we're going to talk about PALS, all right? PALS is a tool you can use to help, I guess, confirm, but also it strengthens your case for when you are trying to diagnose someone with a STEMI. So if I see elevation in the posterior leads, I will likely see depression in the anterior leads. Elevation anterior, depression inferior. Elevation inferior, depression lateral. Elevation lateral, depression septal. Elevation septal, depression posterior. And it kind of flips on itself. So this is relevant because a standard 12 lead doesn't show you the posterior wall, but it does show you the anterior wall. And in that 12 lead that we just looked at, we had ST depression. And I guess to even go further, I am defining that. So I'm taking my isometric line here, drawing it straight across, and this point here is lower, all right? That's not normal. That is considered depression. So if I see depression in an organized way in these leads right here, that's relevant. So things I'm looking for when I'm considering the posterior MI is reciprocal changes V1 through V3. So that includes septal leads as well. Septal leads, you're also going to see depression. Now I know that's not PALS specific, but it is specific to the posterior MI, and it's just one of those things that we got to know, all right? Another thing is going to be horizontal or downsloping of the ST segment. And all that is let's take a look at our ST segment and see how it is sloped this way. So if I had a Matchbox car, it would not sit idle. It would move down this hill. That's not normal. Third thing is going to be R wave progression. And what that means, an R wave is the first positive deflection from the isometric line upwards after our P wave. So we got our P wave here and then R, all right? Typically, R wave progression is through the V leads, small working its way progressively larger with each lead. So if I'm looking through the anterior septal leads and I see an R wave that is proportionally much larger than, say V5, which is, pretty big, but I'm in V1 or V2 and I have a huge R wave, that's not normal. That is one of my clues. So any one of these things isn't necessarily acutely alarming, but I need you to be curious and try to dig a little deeper with some of these patients. A lot of times, our cardiac patient, all patients, but specifically when you're really diving into the weeds of a 12 lead or an ECG, you have to be curious, and instead of trying to, I guess, is this VFib or is this VTAC? Well, what other things could I be seeing? Could I be seeing a STEMI? Could I be seeing a fib? Could I be seeing a block? Be curious and try to systematically analyze. And when you do that, you might catch something like this. So we talked about reciprocal changes, V1 through V3, horizontal downsloping, and abnormal R-wave progression, paired with your symptoms, okay, acute coronary syndrome patient's symptoms. So your patient is symptomatic in some way, shape, or form. They're not just experiencing an abnormality on their 12 lead. It has to fit the piece, okay? So they have vital sign abnormality, they have shortness of breath, they're diaphoretic, they have chest pain, abdominal pain, arm, jaw, back pain, dizziness, nausea, vomiting. These symptoms up here paired with a symptomatic patient, that's not normal, and they warrant a 15 lead. And I'd really like to rule out that posterior wall in mind. If you do a 15 lead and you don't see any elevation in your posterior leads in your V8 and V9, okay, doesn't mean it was a waste of time. Now you have another pertinent negative fact to pass on to whoever you're handing this patient off to. So let's go ahead and actually take a look at a 15 lead. So here it's labeled. So we have V4R, V8, and V9. And if you look, we have elevation, elevation. Very clear posterior STEMI. I have a quick analogy here for you. Moving back to our other 12 lead video, we talked about a house inspection. And we'll say a house pops up on Zillow or whatever app you're using, and it's in your price range, it's in the desired neighborhood that you want, and it looks pretty decent. It looks like they got a new fence, they got a nice little walkway, it's right size and fits all my parameters, but there's really not a lot of photos of the house. Unfortunately, they just have that one photo of the front. You'd like to see more, but there's just not any more pictures there right now. And you think you might see a fire in the backyard? Like, what's all that about? Is everyone okay? You're going to be curious. You're going to want some more answers. This is not too unlike your normal 12 lead. Our 12 lead is going to give us a certain vantage point that is definitely relevant and important, but it is not comprehensive entirely. And so there will be signs that your patient is experiencing an event on the backside. And I need you to, again, be curious and pay attention to those signs that we just talked about. And if they're there, please consider the 15 lead and do it and see what it says. Let's move down the line to right ventricular involvement. And so this is, again, specific to the inferior STEMI. Pardon me. So a standard 12 lead shows you the inferior portion of the heart with leads 2, 3, and AVF. But it doesn't differentiate between the right ventricle and the left ventricle. And that differentiation is relevant. You might treat them differently. So let's look at the right ventricle specifically, all right? So if it's experiencing infarct, its muscles are becoming hypoxic and dying, and they're less able to contract. And because of that, it is very, very preload dependent, meaning that when the right atrium is delivering blood to it, it uses that volume to stretch its muscle fibers, and using the Frank Sterling law, it will then, due to that capacity that it has stretched, it will then contract. Okay, it's like, the more I stretch a rubber band, and when I let it go, the more forceful that rubber band will then contract, and the heart is akin to the same thing. All right, and so it is losing the ability to contract using its muscles, and it's relying on that preload. And so if I treat this patient conventionally with nitro, I'm going to reduce preload. And by doing so, I will then further reduce the right ventricle's ability to contract, and it's going to kind of insult it further. And this might make your patient start experiencing cardiogenic shock more quickly if they're not already. I'm not going to say don't give them nitro. I would definitely loop in med control and have that conversation with them. I'd have a line or two ready and some fluids. Make sure that you're monitoring your patient's lung sounds, and they're doing routine assessments on them every few minutes, honestly. So let's take a look here at another 12 lead. So this is another 15 lead. Sorry, I said 12 lead. It's 15 lead. And we have pretty clear elevation in leads 2, 3, and AVF. So there's our line. Massive elevation. So we have an inferior STEMI. But is the right side involved? Yes or no? Well, they threw V4R, and then we see elevation. So this is a right-sided involved inferior STEMI. That's the modified 12 lead, y'all. That is 15 leads. I think that, again, you don't need to do these on everybody, but I do want you to strongly consider them on your acute coronary syndrome patients. If you think that a patient warrants a 12 lead, I want this to be in your back pocket. I'm not saying you need to get it out, but I want you to at least apply a screener where you're looking for posterior involvement. That the standard 12 lead isn't going to show you that, but I want you to be curious and at least think about it, because this is your patient's life, and you could help them out by doing this. All right. Thank you for your time. You guys have a good day.
Now we're going to talk about applying the 15 lead. Due to the mannequin that I have, it doesn't have limbs, so I'm going to omit the limb leads, but those go on the limbs, not the torso or abdomen. So we're going to be dealing with the V leads as well as the extra 3 leads for our 15 or expanded 12 lead. So let's start with V1. That's going to be 4th intercostal space, just on the right side of the sternum. We'll put it about right here. V2, 4th intercostal space, left side of the sternum. And then we're going to drop down to V4. I'm going to skip V3 for now. V4 is going to be at the 5th intercostal space, mid-clavicular line. So mid-clavicular, and probably right about here. V3 is going to go between V2 and V4. And then we're going to go to V5, which is going to be on the same plane as V4, although it is going to be at the left anterior axillary line. And then V6, which is going to be mid-axillary line, same plane, which you can't really see here. I got V6 right there. And now I'm going to apply my additional leads. So the way these work on the LifePak 35 is they are kind of interchangeable. You have A1, A2, and A3, and wherever you put them, you will then just configure that on the monitor. So I'm going to put the A1 lead in V4R. So it's going to be the same spot V4 is, except just on the right side. So it's going to be fifth intercostal space, mid-clavicular. So I'm putting it about here-ish. And you have to be cautious using the nipple as a reference point. I'm just saying that because this mannequin, they're at different places, and that can be the case for your patient anatomically as well. So now I'm going to take A2, and that's going to become my V8. And V8 is going to be on the same plane as V4, 5, and 6, although it is going to be the mid-scapular line on the left side of the patient. So I'm just going to move this patient around so that you guys can see. My lead's sticking to things. All right. So same plane, mid-scapular, and then my A3 is going to become my V9, and that's going to be on that same plane, just to the left of the spine. That's your 15 lead placement. If you guys have any questions, reach out. Thank you. Now that we've talked about our additional leads, what they measure, and how to put them on a patient, let's use the monitor. So for this, the LifePak 35 for the 15 lead or the expanded 12 lead. I'm going to go ahead and hit the 12 lead button at the bottom. I have my patient already hooked up, and I'm going to see a live view of all my leads. As I scroll down, I'll see my additional leads. And these are A1, A2, and A3. And these are just generic names for the leads that LifePak uses, because you can configure these leads many different ways. And so for the 15 lead, we're doing V4R, V8, and V9. And so I'm going to tap A1, and then I'm just going to relabel it V4R. And I'm going to do the same thing for the other leads. A2 becomes V8. A3 becomes V9. Now if you had these maybe swapped, like maybe you had A1 in the V9 position, you just label it as such, and the interpretation will read correctly. I'm going to then hit acquire. It will prompt you sex and age. I've already kind of gone through this prior to starting the video. So select what's appropriate for you or your patient, and you're going to see a diagnostic view of all your 12 or of all your leads. And as I scroll over, I will see my 3 additional leads on the right-hand side. So let's go through and look at these. This might be a little difficult on the camera, but I'll kind of talk through it, and then we'll go over the analysis, which is pretty helpful. Off the cuff, it looks like I see elevation in 2, 3, AVF, so those inferior leads. See maybe a little depression, AVL. I see depression in V2, V3, V4, V5, no, not V5, maybe. And then swiped over to V4R, I don't see anything. And V8 and V9, I do see some elevation. So, just a reminder, that anterior septal, those leads that I see depression in, those are the inverse, using the Pales analogy, of that posterior wall. And so that's your telltale sign if you were just performing a regular 12 lead, that your posterior wall might be impacted and you should perform further assessment. But for this, we already have them hooked up. Let's go ahead and look at the analysis tab, the STJ Insight, and it shows inferior elevation, so anything above the gray zone, that's red, is going to be abnormal ST elevation, and anything below the gray line is going to be abnormal ST depression. So I see ST elevation in inferior leads, and then all the way over here in the posterior leads, I see elevation as well in the red. And then if you look down here, just to kind of hit the same nail on the head because it's important, I see a lot of depression, all right? And if you see right below that, it's labeled posterior. And all that is saying is that ST depression in these leads are going to be your hint of posterior involvement, and that it warrants further analysis, and that you should consider maybe checking out those posterior leads. Let's go back to live view, and I'm just using a rhythm generator here. Let's do a different type of STEMI. All right, I'm going to hit acquire. All right, same song and dance, but a different STEMI. All right, elevation 2-3 AVF. All right, clear inferior STEMI. Now, I mean, you see some other things here. I see depression. But let's go ahead and ask ourselves that important question. Is this a right-sided inferior? Is it involving the right ventricle? And to do that, I need to assess V4R, all right? So let's scroll on over to V4R, and it does look like there's significant elevation in V4R. Let's go ahead and hit the analysis tab, and that confirms that. You see red in the above the gray area under inferior and right. So right-sided inferior MI or STEMI. And this is clinically relevant for us, very preload dependent patient, and they should be treated as such. That's the 15 lead on the LifePak. If you guys have any questions, reach out. Thank you for your time. Have a great day.